Hello everyone, today we are going to talk about evidence-based tools to evaluate patients who have pharyngitis and pneumonia. We're going to be using the Centor criteria and the CURB 65 rule. Strep throat is a bacterial infection of the oropharynx caused by group A strep that affects more than 500 million people every year around the world. So this is a significant number of people who will be coming into your ED with a sore throat, and you need to know what to do with them. It's a pretty classic picture where a patient comes in with a sore throat and they want a strep test, and you're not sure if they need that test or need antibiotics or just what needs to happen. So it's a good thing that we have an evidence-based tool called the Centor criteria to help us determine if we should use a rapid strep test or use empiric treatment. So the Centor criteria, or the modified Centor criteria that we're going to talk about, is a pretty straightforward system. There are a couple categories: fever, tonsillar exudate, absence of cough, and lymphadenopathy. And for each one of those, you get a point. And then there are age criteria. If you are young, age 3 to 14 years old, you get a point. If you're 15 to 44, you get 0 points. And if you're older, above 44 years old, you get -1 point. So you calculated that score on your patient, but what does that score mean? Well, each score correlates with a percentage of group A strep infection. So as the score increases, so too does the risk of that actually being strep throat. And based on that score, different organizations have different recommendations. The Infectious Disease Society, the IDSA, and the AAP are the more conservative groups, so they're going to recommend for low scores that you don't test and don't treat, and even for higher scores that you do a rapid antigen test before you treat. And that sort of makes sense because the Infectious Disease Society is going to be more mindful about antibiotic resistance, so they're probably going to be more conservative with their empiric treatment. Whereas some of our other groups, after you get above a score of 2, you can test or treat empirically just based on your clinical practice. So after you present their score to your attending and you say you want to get a rapid antigen test and it comes back positive, or you say you want to treat empirically and they agree that that's a good idea, what's your next step? Well, you're going to want to look at your local antibiogram because antibiotic resistance is a big deal, especially with the drugs that we're going to be using to treat pharyngitis. So you want to know exactly what's going to treat that bacterial infection at your hospital. You can use a single intramuscular injection of penicillin G, a 10-day course of either amoxicillin or penicillin V, and if your patient is allergic to penicillin, this is a popular test question. Patients who can't have the first-line treatments, what can you do? You can do a 10-day course of cenflexin, clindamycin, clarithromycin, or a 5-day course of azithromycin. Now, a point that's up for more debate is the use of steroids, and there's growing evidence that giving patients a one-time dose of corticosteroids can actually improve their symptoms and potentially even help them recover. There still needs to be more research done, but this is something that you can pretty reliably propose as part of your plan because whenever I was on my acting internship, I saw it done a lot for these patients. So moving down the airway from the oropharynx into the lungs, we have the CURB 65 rule, which will help us predict the mortality and guide our management of patients who have pneumonia. So this rule is a little bit easier to memorize because it itself is an acronym. So the C stands for confusion, which you can sort of extrapolate to altered mental status. The U stands for urea greater than 7. The R is elevated respiratory rate greater than or equal to 30. The blood pressure is systolic less than 90 or diastolic less than 60. And the age is greater than 65. Each of these earn you a point. So this scoring system, you can commit to memory, but it's also, like all of these, pretty easy to use on MD Calc. Now, what do these scores mean? Well, they basically, similar to the Centor criteria, as your score goes up, things get worse for you, except in this case, it is 30-day mortality. So if your score is low, 0 to 1, you have pretty low mortality at 1.5%, which means you're a low-risk patient and you can be treated at home. As your score increases, so does the 30-day mortality. So if you score 2, you get 9.2%, and this is where things get a little subjective, where you should probably be admitted, but if you have really, really good outpatient follow-up or are an abnormally healthy patient, you can consider close outpatient management, but in my very limited experience, these patients usually get admitted. Now, above this, you're almost certainly going to get admitted. The aggregate risk for 3 to 5 score is 22%, and you're going to be admitted and managed as a severe patient. But it's important to note that the actual risk of a score of 4, the mortality is 40%, and a score of 5, the mortality is 57%. So you're going to be considering ICU admission for these patients. So these are evidence-based and validated tools for clinical decision-making on pharyngitis and pneumonia. The Centor criteria and CURB 65 both have level 1 evidence. That means they are accurate and can impact your clinical decision-making, outcomes, and cost. For CURB 65, it's important to know that there are more accurate tools available for pneumonia prediction. There's the PORT score that was produced by the Infectious Disease Society of America. It has a little bit more validity at lower scores, at people who might be less sick, but it is more complicated and takes more patient factors into account. So for just a quick and dirty version, you can use CURB 65, but if you think you might need more evidence or more predictive power for lower risk patients, you might turn to the PORT score. So, like all of our evidence-based tools for decision making, you should be working to incorporate these into your presentations and working to use them more when you develop your plans so that there is a good evidence base for what you are doing. Also, these two specifically have pretty good utility on your shelf exams during your 3rd year and potentially during your emergency medicine test at the end of your acting internship, whether it be the SAEM or the MBME. So these are a good thing to commit to memory both for clinical practice and for test-taking purposes. These are the resources I use to learn more about these scores, and I definitely learned a lot of the mechanics that go on behind the scenes. And if you want to learn more about that as well, I think these are a great place to start. As always, thanks for listening.